101, we'll be talking about coding for behavioral health. Now, this is a topic that isn't actually talked about very much, and it's a much needed topic, as you know. If you're joining us, then I suspect it's because it was a topic that perked your interest. There is actually so many things that we can talk about regarding coding behavioral health. And I should have said this was Behavioral Health 101 coding, because we're just going to get into the basics. And then later, we'll get into more detail if you would like for us to do that. So the first thing we need to tell ourselves is, what's the difference between behavioral health and mental health? It's actually two different things. So with behavioral health, that has to do with emotions, and mental health has to do with the biological aspect of those emotions. You know, a big word now that I keep hearing people say, I see it in social media, I see it on TV and stuff like that, is the term triggered, right? You probably have seen that as well. And behavioral health is triggered by something, usually things like alcohol abuse, right? That would be an example. Whereas mental health would be treating something that is triggered in the body physically, like Alzheimer's. So you can't choose to remember more things if you have Alzheimer's. Your body takes that choice away from you. It's biological. Whereas with behavioral health, behaviors can change. It doesn't mean that you won't struggle with a situation or a something that triggers you, but the fact is that it is something that could be changed. So a person struggling with behavioral health, they can still face stresses. And here's a bunch of examples. We got depression, anxiety, relationship problems, grief, addiction, ADHD, learning disabilities, mood disorders, psychological concerns. All of those can be a part of behavioral health. And then how is that treated? Well, there's counselors, there's therapists, there's life coaches, there's psychologists, there's psychiatrists, there are clinicians, as well as providers like nurse practitioners and physicians that specialize in behavioral and mental health, as well as your PCP could actually be treating you for behavioral health or even mental health. Mental health, again, is the biological component that you deal with. So if a person has diabetes, something biologically in their body has given them diabetes. Whereas if a person is addicted to tobacco, and they first chew tobacco and then maybe they start smoking, and then before you know it, they're chain smoking, that is considered behavioral health. Now, treating the addiction, the biological addiction, would be a part of mental health. You know, using a chemical to help them wean the addictions that the body, or the withdrawals that the body goes through when you're stopping the addiction. Behavioral health, though, that's really a big umbrella. Mental health falls under behavioral health. So most of the time when you see documentation or therapies advertised, it's going to be classified under behavioral health. And then mental health is a component of behavioral health. Just know that also mental health kind of has maybe a stigma to it, the term mental. Not so much now as it used to, but behavioral health sounds much more pleasant, right? However, remember, mental health falls under the umbrella of behavioral health. What about psychiatry? Well, psychiatry is actually the psychiatrist is a doctor. So he is a provider, and the psychiatrist would practice psychiatry, which is treating and diagnosing behavioral and mental health. So behavioral health, again, being the umbrella, and the mental health being the components that fall under that umbrella. The psychiatry, practice of psychiatry, will allow a patient to actually be treated, get a diagnosis and a treatment. This could fall under things like prescription medication that is prescribed to treat, therapy, counseling. You might have CBT, alternative medicines can all be used to help treat. However, remember that it doesn't matter what the treatment is. If it's, even if it's not a prescription, it could even be things that are over the counter, like St. John's wort helps alleviate depression. It's a mood enhancer. But a psychiatrist could prescribe that the patient goes and gets over the counter St. John's wort, but in turn, the psychiatrist, like your general practitioner that you go to, understands the full body, what everything encompasses. So they would understand that if you are on Coumadin therapy, you wouldn't want to be taking St. John's wort, because both of those are blood thinners. See how it, whereas, a counselor may not have that medical background or that understanding that, hey, that's not going to work together, because a counselor is, a lot of times could be, but is not a medical doctor. And a psychiatrist is a medical doctor that's specialized in behavioral health. Now, that means ultimately, when you boil it down, and that is their specialty, just like if a medical doctor decided to become a cardiologist or a podiatrist or an endocrinologist or an orthopedist or a psychiatrist, right? They're a medical doctor that's specialized. There is not just medical doctors that specialize, but nurse practitioners also will specialize, physician assistants. I don't know PAs. I don't know if I'm sure they have to have that specialty, but I do know nurse practitioners. With psychiatry, though, keep in mind that state law plays a part. Now, because individual states help with treatment of behavioral and mental health, and with specialties, for example, there may not be the ability in one state to work as a nurse practitioner who specializes in psychiatric medicine versus a doctor. But that's kind of across the board when it comes to nurse practitioners and PAs. So depending on whatever your state is. Now let's go back to behavioral health. Remember the umbrella. We have things like substance abuse and addictions that fall under that umbrella. You can have disorders that are illnesses, but they precipitate or perpetuate the ability of a person to make decisions, or the ability to resist certain things like smoking tobacco, or taking cocaine, or say it's an illegal substance, whatever you want to fill in the blank with, even if they know it has negative consequences. I know that one of the more addictive, or I don't know if it's the most addictive, but one of the most addictive illegal substances would be heroin. And they say that it just has to be used once before the body will become addicted to it, and it changes the personality of the person and the person's ability to make decisions based on the reality of the consequences. So in other words, you'll do anything to get more of the substance without caring what the consequences are because the body needs it so bad, that type of thing. And then there's an aspect of that that changes things like compulsive behavior and makes it into a behavioral health disorder. And again, this is a fine line with the diagnoses that a psychiatrist would be able to do with the help of psychiatric counselors, et cetera, with the treatment. That, you know, where does it become a compulsive disorder, move into being a behavioral health disorder? Right. It's one thing to have a compulsion to wash your hands 3 times, you know, after you eat, or touch your nose repeatedly or something like that, versus having a compulsion to go out and do something destructive. I don't know why that slide was blank. Mental health. Now let's talk about some of the examples that would be classified as mental health under the behavioral health umbrella. Bipolar disorder. Now what would have been really beneficial is if I would have gone in and given you diagnosis codes for some of these, but these are so broad that with the diagnosis codes, we could give you kind of a code range. But bipolar disorder, and don't get bipolar disorder confused with manic depression when you go to code. Those are 2 separate disorders. Schizophrenia, and there's all types of schizophrenia. Depression, we have all types and levels of depression and causes of depression, right? It's some environmental depression versus having a person that is feeling depressed over a long period of time that they can't seem to pull themselves out of it. So you know, we think like environmental depression would be a spouse who loses their loved one, their, you know, spouses, one of them dies. Of course, there's going to be stages of depression, and there's not really a time limit on that stage of depression. You know, there's like what, 7 levels of grief that they say you go through, you know, but that would be expected. That's normal. That's within the norm. Whereas if everything's going great in your life and you have this overwhelming feeling of depression and you can't figure out why, that's different, right? There's something else going on, and it could be something physical in the body, like a thyroid condition that will affect your mood and cause depression. You know, a psychiatrist would be able to help determine if that's the issue, working with the medical doctor. And so again, the medical doctor, when you let them know that this is, you're exhibiting these signs and symptoms and they're treating the medical aspect of it, you may need to have the mental health aspect of that condition treated at the same time, side by side. Generalized anxiety and anxiety disorders, social anxiety. Now, there's the normal type that we expect, if, you know, a person not being able to stand up in front of a crowd and give a speech. There are people that said that, you know, statistically, they fear standing in front of a crowd and public speaking more than death, which I can understand that. I've never had that type of a fear for speaking in front of people, but that's my personality, where I know a lot of people that, you know, will go throw up. They can't do it. And another disorder that falls under mental health would be ADHD, attention deficit hyperactive disorder. And don't forget the hyperactive in there, because there's ADD, attention deficit disorder, and there's attention deficit hyperactive disorder. which tends to get more attention because if you're ADD, your brain just snaps, right? But if you have the hyperactivity involved there, you're bouncing off, your children's bouncing off the walls, or that person is, can't sit still. And of course, that's going to give attention. Behavioral health disorders would include substance abuse disorders. Now, this should read behavioral health at the top, not mental health. Substance abuse disorders, again, eating disorders, and behavioral addictions. Substance abuse disorders could be something as simple as tobacco to heroin. They're both substance abuse disorders. Eating disorders, of course, the common ones that we think of are bulimia and, anorexia nervosa, and you can have one or both. And behavioral addictions, where a person is, surprisingly, one that you might not think of as commonly is, if you heard of people being adrenaline junkies, right? It's an addiction to that high that they need, that they get to experience something bigger and bolder. So you got these people that will jump off a cliff with like paragliding and stuff like that, and base jumpers, I think they call them, where they go up to a really tall building and jump off, and then they just have to get higher and higher and stuff. If you have a compulsion where you can't stop that, then it becomes a behavioral addiction. Right. And behavioral addictions can fall under things as well as a desire to not only put yourself in situations that are dangerous for yourself, but think of things like sexual addictions, where a person has a compulsion that they have to go out and meet strangers, in a bar or whatever. And there's classifications of all types of things that are extremes. And again, it's an addiction, which is classified as something that you can't control. Under behavioral health, going back to that, there's different types of therapies that you need to be aware of. So if we're going to code these now, then we need to know the type of therapies that work for mental health as well as behavioral health. Cognitive behavioral therapy, or CBT, is very popular. It addresses both the behavior aspect as well as the mental aspect, and they want to figure out, what's the cognition and the behavior, what's the two, what's links these two. So kind of like the cause and effect of it. They'll use therapy and speak with therapists, or it won't necessarily have to be a psychiatrist, but a lot of times you'll go to a behavioral therapist or a cognitive behavioral therapist, and they find that link and they work on the emotions and behaviors to change the way you think, so that you're not driven to repeat the behaviors that are dangerous, or other types of things like stop smoking. Motivational interviewing, that has been also quite popular, where you set up a goal-orientated therapy. So what's my goal? What do I need to do first? Let's say you have a compulsion or an eating disorder. So what's my goal? My goal is to eat 3 meals a day for a week. Okay. So that's what, you have a goal, and each day you're going to try to eat 3 meals a day. It doesn't matter how much you eat and what you eat, but your first goal is to eat 3 times a day and for a whole week. And then you start breaking out, and once you achieve that goal, then you achieve a new goal. I'm going to have a starch and a protein in each one of my 3 meals each for an entire week, etc. So you build on that. They also, with motivational interviewing, they will work on uncertainty, ambivalence towards change. Now, if a person has, for example, an eating disorder, maybe they don't feel like they can change, or they don't want to change. A lot of times you have body dysmorphia in there, where it doesn't matter, even if they look in the mirror and you see someone that's skeletal, they see obesity, right? And so they're ambivalent to trying to change. And so that is working on goals to help them see that. A lot of times people that have addictions, this works to help them recognize what the addiction is being caused from, and then in turn empowering them to stop that addiction. There's also reality therapy. This is used to treat behavioral addictions, and what the emphasis ends up being is you have choices to determine your behavior. So if you have something in reality that happens, then how are you going to face that reality? So you got to be first willing to make changes, and you've got to be able to embrace altering behavior to be able to change. I guess the addiction is the best way to say it. With reality therapy, they really want to establish new behaviors and strategies so that you take care of 5 basic needs. And they start with survival, love, belonging, freedom, recreation, and power. That seems like that's 1, 2, 3. Oh, love and belonging is together. I was going to say that's 6, but love and belonging together. So with reality therapy, then again, you set your goals, and those are the 5 things that you want to take care of. Most effective, they found, though, is counseling and medication to help. So giving a person the ability to talk through what they're going through, what they're feeling, and having suggestions given to them to alleviate that, and then having a chemical medication to help ease through, to like if a person's going to stop smoking, there's a medication that will suppress that need for nicotine. Or even if you get nicotine, it makes you sick, right? So counseling along with that, so you can talk through when do you most often in a day want to have a cigarette? Well, when I first get off of work and I feel like I'm detoxing and wanting to calm down, so I'll take a cigarette. Or I've heard people say, after they eat, it's like a habit. They've got to have a cigarette after they eat, like they earned it, things like that. Early treatment really works with this type best, and it's important to make sure that you're getting to a professional that can help with both the counseling and the medication, or work in tandem together. So using a diagnosis that would constitute medical decision-making for a medication, right? And usually it's a compound or group of things that help in these situations. So it's not just medication alone. You need counseling and medication, and maybe group therapy, et cetera, depending on what it is that you're working through. But ultimately, this last statement, treatments must address each person's needs and symptoms. And everybody's different, right? Statistically, they know what works for most people. However, it's not going to work for everybody. And by going through counseling and doing a combination of things with the help of a professional, allows them to tailor a program or goals for that patient to go through. Now we'll talk about coding. What I want to say that's really interesting about the aspects of coding for behavioral health is that, in the past, this got very little to no attention. That's why people are scrambling now to learn more about it, because insurance pays, for it. It's a hot topic out there in the world. It doesn't have the stigma that it had even 20 years ago, or even 10 years ago. Plus, as a society, I think we've come to the terms and we realize that behavioral health is so important, from even things as simple as addiction to cigarettes to something broader with an addiction to maybe an illegal substance, right? And not just addiction, but other things like suicide rates being so high, suicide rates in children, suicide rates in professionals that are, for example, paramedics or first responders, firefighters. They used to say that burnout for ER staff back when I was doing the working actively in the ER was 3 to 5 years. And whenever you knew a nurse that specialized in that scenario and they were in that for a very long time, more than 5 years, then they usually took breaks and jumped into another area of the hospital for a few years to give themselves a little bit of time. Maybe they went to OB, right? Because that usually is a very uplifting and fun area to work. Not that they don't have their tragedies, but it's by far a much more fun place to work than an ER where, a lot of the time it's trauma and tears and grumpy people because they're unhappy and uncomfortable in life-threatening scenarios. So again, suicide prevention falls under behavioral health, as well as addictions, as well as things like, I would say the 80s and the 90s, bulimia and anorexia was a big thing that everybody was talking about and trying to work at treatments, but insurances didn't pay for that because it was behavioral and mental health. But now it does, and everybody again is scrambling to get information so that they can code properly, they can document properly, they can bill properly, so that as well as the insurance companies, kind of now that they are paying, coming up with standards, right? And we all need to be on the same page. So let's start with psychotherapy. When we look at the CPT codes, and again, that's what we're going to focus on today is the CPT codes, because with reimbursement, the ICD codes, they've never changed per se. There's nuances and stuff, but that wasn't what your reimbursement was based on. So, that is, to me, a little bit easier than when you're dealing with CPT codes. Now you got to make sure you get all of that right in the documentation so that when it's sent off and billed, we want to get to the highest specificity, not just for statistical purposes, but we want our providers to be reimbursed for the work they're actually doing. So as a coding professional, you are that liaison, that translator, and you're working with the clinicians and the providers to assist them and train them, as well as them training you, maybe the dynamics of what they do so you can code to the highest specificity. So face-to-face only, let's look at a few of these codes for psychotherapy. If we're doing a psychiatric diagnostic evaluation, okay, it's a 90791. Now, this is as of February 2019. Okay, if we're doing psychotherapy and we're doing 30 minutes with a patient, now there's a difference. Psychiatric diagnostic evaluation, I know there's a problem. I just got to determine what the problem is. So it's a diagnostic evaluation. It's like going in and doing an X-ray to see if there's a fracture of a bone. So now we know there's an issue, a problem. We're going to do a diagnostic evaluation to determine what is the problem. With psychotherapy, then we start looking at time. So 90832 is going to be 30 minutes with the patient. Now, what does that encompass? And this came straight from Find a Code. So if you're doing the individual psychotherapy, and some of it's individual and some psychotherapy is in a group setting, so you got to make sure you're getting the correct one. You're going to provide a patient with utilizing re-education, support, maybe reassurance, insight discussions, occasional medication to affect behavioral modification through self-understanding, or to evaluate and improve family relationship dynamics. But again, you're one-on-one, one person, and to relate to a patient's condition. Couple examples of that might be a patient going in for psychotherapy because they've recently lost their spouse. Okay, and they just can't seem to get out from under this ongoing depression, and maybe some medication is going to help alleviate that mood, lift them up a little bit. Um, and or maybe they're sleeping so much, but they're not sleeping quality. And so they give them a medication to help them sleep better, get a better quality of sleep. It's not, I mean, it's a sleeping pill, but it's the fact that they're sleeping fitfully. Maybe it's a person who has been involved with something traumatic. They, were in a motor vehicle accident, and the person next to them died in the motor vehicle accident, and they just keep reliving the accident, something that was out of their control, maybe. And there could be things like behavior modification that they're working through. They want to stop smoking. They got to talk through it, set goals, and then they're also taking medication to help them wean themselves off their addiction. Notice that with 90832, we have 30 minutes with the patient face-to-face. And then other codes could be 90832 would be 30 minutes. If we're 45 minutes, it's 90834. If it's 60 minutes, it's 90837. And if they do a medical evaluation and management services, then you're going to jump over to 90833 for 30 minutes. Then you've got 90836 for 45 minutes and 90838 for 60 minutes. So we have, again, one, psychiatric diagnostic evaluation. We're going to determine what's wrong. Once we've determined the issue, then they're going to start psychotherapy, for example, face-to-face, one-on-one. So if we just do 30, say we scheduled 6 30-minute sessions, then 90832. But if we do a diagnostic, okay, on one day, then we come back and we know what the problem, the issue we're going to focus on is now, and we do an E&M psychotherapy, then 30 minutes, 90833. And then after that, we're, it's, not got that E&M, we're going to start doing the 90832. Right? So what you need to do is focus on the time, whether it's face-to-face, and if it's group therapy or not, individual. Another code would be family psychotherapy. Now, notice in the brackets, without the patient present. That needs to be highlighted. All right, so if you go to 90846, that means we're doing a family group, we're talking, but the patient, the person that has the issue, is not present. 50 minutes. And then here's some examples of things like how to deal with stress, anger, grief, interpersonal conflicts that are involved with other family members. Sometimes you have family therapy is needed when you have one patient that has a mental health condition. Maybe it's a relatively younger couple, and they have teenage children, and the husband develops Alzheimer's, early onset Alzheimer's. That's pretty devastating to, say, be in your 40s or 50s and developing Alzheimer's, and that's going to affect the entire family. So the patient that was diagnosed with Alzheimer's is not present if you're going to use a 90846. And so we're going over, hey, how are we going to cope? What are the things we're going to expect? And, you know, moving forward, you know, what's our goals, things like that. Continuing on with that same code, they will look at things like family roles. You know, that now the father is not going to be able to, slowly he's going to lose his ability to be that father figure to the children and be that, you know, spouse to his wife. So, you know, what are the dynamics of these relationships going to be? Therapists will suggest ways to interact with family members and stuff, and you can read the rest of this on your own. Now, if, again, you use 90846, it's for 50 minutes. It's family psychotherapy when a specific family member, the patient, is experiencing personal challenges and is not present. Okay, so 90846, not present. You need to make a note there. If you use our BAT technique, right, then that's going to be bubble and highlighted in there, and that's going to be written off to the side. Now, if you use 90847, that's your 50 minutes of conjoint family psychotherapy with the patient present. Okay, so that's what you have to ask yourself. We're doing family psychotherapy. We're doing it for 50 minutes, but is the patient present or the patient's not present? That determines your code. Let's look at 90785, interactive complexity. Now, there may be other codes that you code with this. So again, straight from Find a Code, the AMA guidelines is telling you that you can use these 90785 with diagnostic psychiatric evaluation, and then they tell you it'd be, you know, for example, 90791 and 92, or if you're going to do psychotherapy, which is the 90832, 34, and 37, which we talked about. You could have psychotherapy when performed with an E&M, and then there's a list. I'm not going to read those codes out to you. Or group psychotherapy, 90853. Now you're asking yourself, oh my word, how am I going to remember all of this stuff? You don't have to remember it because it's actually in your manual. All right. So this came straight from Find a Code, and you bring up the 90785 and you look at it in your manual. This will all be listed in there and say, hey, heads up, pay attention to this. But when you use 90785, you are not going to code that with the two codes 90839 and 40, right? Or if you're going to do E&M services and there's not going to be psychotherapy associated to that, okay? And also don't use that code with a few other codes that they've listed here with those little baby codes, remember, that end in a T. If you do a separately reportable psychiatric service, right, and you're going to do treatment to the patient with it stating factors related to the difficulty in communication, increase the complexity of the encounter, what do we do if we have a complication with the patient being able to communicate? So let's say we're doing psychotherapy with a patient that has Down syndrome that, although is mentally very, the acuity for this patient is very, very high, but they realize that there are some concepts that this patient's not getting, and they're not able to communicate as not being able to verbally communicate their thoughts and feelings. Then what happens is you have someone else that's going to step in and help that patient. It could be a parent. It could be a guardian. Now, if there is not a parent or guardian, again, you could be involved with state agencies, courts, or maybe a school personnel is helping with a child. There could be language barriers and you have to use an interpreter. So what do you do if you have a person that is English isn't their first language? Well, then let's say it's Spanish. Well, they're going to want to find a psychotherapist that's Spanish speaking. What if it's that they're deaf and their primary form of communication, their first language is ASL, right? It's a whole lot harder to find a psychotherapist that knows sign language than it is that someone that knows Spanish. So maybe you have an interpreter involved. Now, we're not even talking about HIPAA and all this other stuff that goes in with that. But again, you have to be aware of what would make those scenarios different. They would not be considered group. They would still could be one-on-one when you have an interpreter, even though another person is in the room. So don't get that confused. Let's see, going back to 90785 for interactive complexity, that can be an add-on service that you can put on there due to the time delay and using an interpreter, or that it's for a child and the parent is involved or guardians involved. When you use this 90785, you need documentation to prove why it is being used, right? What is the scenario? Now let's look at 90853, group psychotherapy. Now this is different than having multi-family group. Okay, so it's not multi-family group. This is group psychotherapy. Be aware of what you can use in conjunction and what you cannot use in conjunction with those codes, right? Group psychotherapy, what does it actually mean? That means you've got several people, they have something in common. Okay, they're a group of people that are trying to stop smoking. So they're going to meet together and they're going to go through therapy together as a group, right? They have something in common. They give other examples like divorce, job loss, a difficult medical condition. Maybe I had gastric surgery and they had group psychotherapy sessions for people preparing themselves for how their life would change. Cancer, Overeaters Anonymous, you know, things like that, those would be considered in group therapy sessions, something that they have in common, but it's not a family type thing. Now, if you have two people in a family that go to a group, that's not the same thing as a family, right? The issue isn't for the family. The issue is that all of these people have something in common. Okay. They usually talk things out. They are a support group with a psychotherapy, right? And then they have a therapist that moderates and gives them or triggers them into things that they want to discuss. A lot of times when they do this, they meet on a regular basis, and it can be between 1 and 2 hours when they do these therapies. Now let's talk about another CPT code if we're doing consulting psychiatric provider. So it's a consulting psychiatric provider, face-to-face only. If we're doing an evaluation with medical services, psychiatric, it's 90792. If we're going to do E&M services, evaluation and management, in other words, so for the first visit with medicine components, we've got a range of 99201 through 99205. So we're leveling with regular E&Ms. That would be a new patient. Then if we're doing established patients, we were going to use our regular E&M codes 99211 through 99215. And you can use other you can use psychotherapy codes to be added to the E&M codes if you need to, if they're applicable. Those would be based on time. Notice we've got 16 to 37 minutes, 38 to 52, and 53 plus. Why they pick those times, instead of 15 minutes, but 16 to 37, I don't know. Maybe somebody else knows why that was done. But your codes are 90833 for that individual psychotherapy. The first time, 16 to 37 minutes. We have 90836, so we got our 38 to 52 minutes. But then, if something runs for almost an hour, 53 minutes and over, we've got 90838. Remember, psychotherapy codes can be added to E&M codes when applicable. If we're doing a psychotherapy complex interactive, now you're going to add this to a code for primary procedure. We're going to look at 90785. What about if we do an SBIRT, brief intervention? All right, this is a specific type of services, and I get it confused with another one. I believe this one has to do with alcohol. Please forgive me if I'm telling you incorrectly. I'm trying to remember. But we have 99408 for private. If we're using private payer. If we're using Medicare, we're going to use a G code, and for Medicaid, we have an H code that we can use. These are going to be 15 to 30 minutes. They're going to do a full screening, but a brief intervention for substance misuse. And again, I think this is one that's directly related to alcohol, but I might be wrong. Now, if we're going to do over 30 minutes, then for private insurance, we're going to use 99409. For Medicare, G0397, and Medicaid, we have the H code of 0050. So notice how a lot of these are going to be based on time. Just about everything has, with behavioral health, has a time component. But don't forget that in and above time, we have to pay attention. Full screening, brief intervention, right, are involved. It doesn't say and or, it says and. What happens if we're going to do a Medicare BHI collaborative? Okay, now if we're being billed under the PCP, then that can be done based on 70 minutes. The first 70 minutes, notice in the first calendar month, okay, 99492. If we're going to do a subsequent calendar month, then it's based on 60 minutes, 99493. Then with 99494, it's an add-on code each additional 30 minutes in any calendar month. So you can use 99494 with 99492 or 99493. Then we have a minimum of 20 minutes. So if we're just doing 20 minutes in 1 month for general BHI services, 99481. Okay. What about G codes for FQHS and RHC practices? Well, these are, again, going to be unique scenarios. Notice they're time-based as well. They are Medicare, so we've got HCPCS codes that we're dealing with, G0512 and G0511. If we look at G0512, minimum of 70 minutes. So we got to use more than 70 minutes. It's the initial month. So dates are going to be very pertinent on this documentation. And then you get 60 minutes subsequent months of psychiatric collaborative care. That's what that falls under. But with G0511, 20 or more minutes in a month of your GCMI. Now, this particular place that I got this, I put all of my resources at the end of this lecture. So feel free to grab those and go do even more research. This particular article had said, hey, here's some helpful places that'll help you, be beneficial to you. Now, what if we do the PHQ-9 screenings? And this is going to be by the PCP. If we're Medicare, you have to note they are only going to pay out once a year for this. You can only do it once a year. There's no co-insurance or deductible for the patient. Okay, now this is Medicare. They do all types of screenings, but they like to use the PHQ-9. Kind of because it's a standard, I think it's accepted. We'll use the G0444 HCPCS code for depression screen, and it will take 15 minutes. There's actually, you can go out and find it. It's almost like a table for the screening. It's pretty quick and easy to do. They must have the ability to provide patients with who screen positive internal services. So in other words, if they screen positive for this depression, then they need to be able to follow up. They can't just walk away. Yep, you're depressed. Thanks, we got it identified. No, they have to be able to have staff-supported referrals and a way to get the patient into services. Sometimes the primary care provider will get them into an outpatient hospital, independent clinic. They've got the FQHCs and RHCs as well. Now there's other health plans. What do we do in those scenarios? Not Medicare, other health plans. We've got the code 96127. Now this code is kind of a catch-all code because there could be all kinds of reasons why they're going to want to do this particular screening. Brief emotional or behavioral assessment is kind of what we're dealing with the 96127. My formatting changed. That should have been screening and then tools up there. Sorry about that. I noticed it did it on the others. Things that they could be looking at would be ADHD. They're saying anxiety, substance abuse, eating disorder, or suicide risk. They want to see if you fall into suicide risk. Make sure that you know that for depression, you could be adding the Z code, which is an ICD code, Z13.89. That would be a good idea to have that code written in next to 96127. And then by your Z13.89 code, having the 96127 written in there, and maybe page numbers or something so that you can look at any guidelines. When you're being reimbursed for this, it's noted $6 per screen, and you can use up to 4 screening instruments per visit. Now, when they mean instruments, they mean tools, right? But for billing on the initial screening or monitoring, responses to treatment, how are they doing now that we've identified it and we're monitoring the treatment process? There's no limit on how often you can bill that. Again, I'm sorry that that is formatted odd. I went in and changed it, but must have been something. What do we do when we bill? What do we need to know about billing health and behavioral codes? All right. So now that we've talked about these main codes for CPT, what do we need to know? That whenever we do psychosocial treatment with medical problems, if you're going to bill these, you need a diagnosis to back it up. All right. So it's one thing to have a code to screen, but after that screen, so there's got to be signs and symptoms to be able to code for screening. After you have a screening and you get a determination, a diagnosis, we did the screening and now we know this, the patient has ADHD, or they have insomnia, right? Or they have a thyroid condition that is causing them to have anxiety and depression. because you're chemically imbalanced in the body. And if you don't know, thyroid medication can take up to a year to regulate. It's not oh, you weigh, 150 pounds, you're female, and you're 50 years old. So, and your lab results stated that your thyroid level was X. So we know that you have to have 25 milligrams of this particular thyroid medication. No, it's not like that. They start you on a dose, and then they keep having you come back in and check your dose, and they keep asking you how your signs and symptoms are. And it can take a year, it could take longer than that for it to be regulated. And then something can happen and it can mess it all up for you. So while they're figuring that out, one of the signs and symptoms is anxiety, insomnia, depression. Those are all signs and symptoms of having something wrong with your endocrine system, and the thyroid can mess a person up faster than any other organ. So you're going to have behavioral health involved, whether the PCP is doing it or not. Maybe this patient needs to go to counseling for their depression and their anxiety while they're getting regulated on this medication. And of course, they're going to come in and have screenings and checks to be done frequently to make sure that not only their signs and symptoms are being relieved, but that their levels in their system is showing what they want. It can be things, even diabetes. When you say you're newly diagnosed with diabetes, and it's like, being tripped. It's like, what do you mean? Now I got to change my whole lifestyle, etc. Psoriasis, if that you didn't think about that, because of what it does to the skin, and especially if it may look like you have red and tindered and scaly skin, it can emotionally bother people. Here is a great link that you can go to that has a tutorial on that. If we're going to do screenings for PCPs for depression, a Medicare depression screening, G0444, again, Medicare. 96127 for the emotional and behavioral assessment, and you can use other screening tools. They can include this for that PHQ-9 for depression. And that is it. If you have any questions, feel free to come in and look at the CCO Club, ask your questions there. Or if you have something you want to share, let us know. And again, this is just the tip of the iceberg. There's so much more. If this is an area that you're interested in, please come and check with us, because in the future we'll have more lectures on behavioral health and mental health. Like I said, we just started with the basics and kind of the background, but we haven't even got into the ICD or the ICD-10 PCS that would be involved. So I look forward to talking about those in the future for you. All right, thanks, and goodbye.